And you guys let me know when we should begin. Should we begin right away?
No, we wait for some for people to
join.
A few minutes to join, and we can just say hello. And I can say, yeah, hello, buenas tardes, buen día, bienvenidos todos a nuestro.
Good afternoon, good morning, and welcome all to this seminar, which has returned at popular request, which is wonderful. And once again, this year we're doing this again, hoping that it will reach more countries so that they use the tool developed by the Collaborative Center of the WHO and PAHO in Canada, CISUR. And hopefully you'll be able to use the results to promote policies and implement them. We are waiting for more people to connect, maybe 2-3 more minutes. And I want to let you all know that we do have simultaneous interpretation into English and Spanish. There is a globe icon at the bottom of your screen. If you click on that globe, you can choose the language of your choice and what you want to hear, or you leave it. If you're bilingual, you don't have to select any language. And according to that, you can just listen to whatever you want. You can put your questions in the Q&A or in the chat. We will be monitoring the chat and the questions so that we can respond to these. It's a pleasure to have you here. And for those of you who don't know me, I am Dr. Maristela Montero, main principal advisor on alcohol in PAHO, Washington, and a pleasure to meet you all.
One more minute, and we can start, and people will continue to join, I suppose, but we don't get delayed, right?
Yes, they will.
Nice to see everyone saying hi in the chat.
Yes, some people with whom I worked before, and good to see them here.
They still talk to you. That's good.
Yes. And to everyone, this meeting will be recorded, and the recording and the presentations will be available soon after the webinar. Okay, 1:05, and team, I pass the floor to you.
Oh, great. Thank you so much, Maristela. And thank you for having all of us and convening this lovely webinar. Today's topic is estimating alcohol harms and modeling alcohol policy scenarios using the international model of alcohol harms and policies. My apologies for speaking in English. I am Tim Damey. I am the director of the Canadian Institute for Substance Use Research. And we are also very lucky to be PAHO WHO collaborating centers on alcohol policy for about 1.5 years now. We have some wonderful speakers today. Adam Shirk is our newest scientist at the Canadian Institute for Substance Use Research. And Adam is the person who, along with Tim Stockwell, but he led the development of the Intermap application that he'll be presenting on today. And then we're going to do a case study of using this application in Chile. So we have Pablo Norambuena Cardenas, my apologies if I mispronounced that, who's an advisor to the Department of Mental Health in the Ministry of Health in Chile. And I heard that he was recently nominated as Director of Mental Health in the Ministry of Health. So we're very honored to have him today. And also Bert Kempfe, who's an advisor in the Department of Mental Health in the Ministry of Health in Chile. So we'll see how they've had experience working with the Intermap project. And then we're going to have a sort of another presentation on the potential health impact of an alcohol minimum price in Quebec in Canada, presented by Tim Stockwell, who many of you know, who's the former director here at CSER. So without further ado, we'll go ahead and turn over the show to Adam. Adam, thanks so much.
Thanks, Tim, for the introduction. I'll just share my screen here and bring up my slides. Hopefully that's sharing correctly. I'm sure someone will let me know if that is not the case. So yeah, thanks for that introduction. Thanks so much to everyone for coming today. Really excited and interested to talk to you about our model that we developed here, like Tim said, at the Canadian Institute for Substance Use Research, the model that we call Intermap, or the International Model of Alcohol Harms and Policies. Today, like my part of the presentation, I'm going to basically tell you what the model is, what it could do for you, you and your research teams, what you may want to use it for in terms of your alcohol policy and alcohol caused harms work in your different jurisdictions. Yeah, so like Tim said, I'm a scientist here at CSER and with the WHO Collaborating Center. So those two things that I mentioned already, what is the Intermap model and who is it intended for, who should be looking to use it, the types of things that it could do for you. And then at the end of my presentation, I'll also talk just a few slides about what data and information you would need to be able to run the model, because that is sometimes a piece when we work with different countries, different regions, what data do we need to use this model? And then I'll briefly do a few examples of Intermap in use as well. I know our other two speakers, two sets of speakers are also talking about that, but we'll look at how we use Intermap for our national cost of substance use study in Canada. That's a Canada-wide project, a national project here. We'll look at an example of how we used it in Finland to do an alcohol policy modeling project around their alcohol retail monopoly. And then the most recent one that I've been working on, we've been working with New Zealand using Intermap to build a national alcohol harms monitoring system. That last one, the minimum unit price project with the underlining, that'll be done by my colleague here, Tim Stockwell. So I thought I'd start with like a statement of purpose, like what was our intent when we thought about designing Intermap and then releasing it for use. So really what our purpose was here was we wanted to, we noticed when I started in the field almost 10 years ago now, we were thinking a lot of people are estimating alcohol caused harm, but they're doing it in a lot of different ways. The methods differ quite a bit. And so it was hard to compare country to country between those methods sometimes. So our first kind of purpose was to help standardize those international methods for estimating the alcohol caused harms. So alcohol caused harms like the death and disability that alcohol is responsible for in our societies. And then another primary goal of it was to make the methods that underpin our model more accessible to more teams, right? So for example, in countries with fewer resources or just the team is smaller, it helps to kind of get these methods out there for use and more people can use them that way. And then another thing that we were interested in, and this is still developing, but we've had some luck in this as well, is it kind of provides this collaborative platform that users around the world can provide input towards the improvement. You know, if there are things that need to be added or stuff like that, people will email us and then we'll work to build them into the next version of the model. So now, you know, what is it? What is Intermap? So what we have here is it's an open access model. It consists of methodologies and then a software portal that you go to, and you put all your data into that portal. So it assists research teams with finding or estimating alcohol's burden of disease. And then further, either you don't have to do both of these, but you can then additionally look at alcohol policy modeling scenarios. And teams provide their region-specific drinking data and their health data, like the number of deaths, for example, or the number of hospital stays. So that makes it tailored to the region in particular. When you put in your alcohol use data, your prevalence of alcohol use, how much people are drinking, that will tailor the results to the region in question. And then just kind of to underpin some examples of questions that Intermap can answer or has been used to help teams answer, right? We would ask things of it like how many deaths or how many disability adjusted life years were caused by alcohol in 2020 or 2022. And then on the policy side, what we can ask is something like this, and this is more what the two teams of case studies we'll look at after my presentation. Something like if an alcohol minimum unit price or another alcohol policy was implemented, how many lives would be saved? How many fewer deaths would be caused by alcohol? How many dollars would be saved? That's something that could be spun off of it if you had information on healthcare costing. So those are the types of questions that Intermap can assist you in answering. And then the open access part. So we thought a lot about this when we first developed it, like, should we charge for it or but we're not. We just decided to have the model for everybody. It's something that we use a lot as well in Canada. So it's freely available at that website there. You can type it in now and have a look at it if you want, and it'll show you kind of what I'm talking about as we go. So free for everyone to use. Who is Intermap intended for? What we're really thinking about here is alcohol research teams that are already working and estimating alcohol's burden of disease or want to get into that type of work, the epidemiology behind alcohol. And then further, policymakers or alcohol policy teams that are considering alcohol policy changes, or maybe one has been implemented already, an alcohol policy change, and you want to evaluate the effect of that policy. And what Intermap helps here is how would that policy change impact population health? How would it change the number of deaths caused by alcohol or the number of hospital stays that alcohol is responsible for? And then just to reiterate this, so the region can be a country. It's often a country, can be like subnational jurisdictions. Like in Canada, we have provinces, states, even cities of a certain size. Like say they were 1 million people or more, then you could run it in a city-specific basis. Even less people than that. Or a health region if that's how your country organizes their healthcare implementation. So this is just to say it doesn't have to be a very large grouping, a very large region. You can look at smaller subnational or sub-state level regions as well. And I want to give credit where credit is due. So when we first developed Intermap, it was led by myself and Tim Stockweller here, but also co-authors were Jürgen Riem and Kevin Shield, who work with WHO on, for example, their global status report on alcohol and health. This wouldn't have been possible without them. So always credit where credit is due. And so Intermap has really become this first open access alcohol harms estimator that everyone globally can go to and use if they like. There is nothing really like that before this, where the methodology was all open and you could put your own data into the software, which is online, and the software will return the results to you kind of in real time. first released back in 2017, amazingly. It doesn't seem that long ago, but I suppose it was. So now we have been building new versions, improving it as we go. So we're up to version 3 that came out in 2020, a little bit more ago. So I just want to reiterate, no software is needed like on your end. You only need that internet connection. You just go to the website and you're able to upload your data in, for example, Excel form. You know, you upload your data into the tool and then the tool returns, the software returns the calculations to you. So you don't need anything on your computer other than that internet connection. It allows the study of policy changes on alcohol attributable, alcohol caused health impacts. And it's been used around the world in different places, namely in Canada, Australia, New Zealand, those other countries there. So when we first came out with Intermap, we published a series of articles that what the articles did was they formalized the methodologies behind the model, but then they also provided examples of use. So of course you can look at those articles, but what I want to show here is those examples of use. So they're kind of like, there were 3 main things that the model could do. So we had 3 articles, each of them looking at one of those main functionalities, and also describing and formalizing the methods. That the bottom right one is the one that Tim Stockwell, my colleague, will present on at the end. Very nice presentation that he has ready to go. And so this kind of just, I want to make it clear what Intermap can do. So these were the examples from those articles about what Intermap can do. So its kind of base functionality is helping to estimate the alcohol-caused burden of disease. And in this example, we have deaths. So Intermap can help you estimate the number of deaths caused by alcohol in your region. And so our exemplar that we have in that journal article at the top was in Canada. We applied Intermap to Canada and we asked, how many deaths did alcohol cause in Canada in 2016 was our year of study. And so we found, right, it does it by males, by females, by different age groups. And we, Intermap helped us to calculate that, estimate that number in red, which is that in 2016, alcohol was responsible for just about 15,000 deaths in Canada. So quite a high burden of disease in Canada. And Canada is quite a heavy drinking country. Many people in Canada use alcohol or, you know, a fair amount of alcohol. So the burden of disease is quite high that is caused by alcohol. This one is about the potential health impact of an alcohol policy, the minimum unit price. This will be described in Tim Stockwell's presentation, so I'm going to move to the third one. And then the third piece that Intermap can do is it can divide alcohol users, drinkers, into different groups based on how much they drink. And then it can help you estimate the burden of disease experienced by each of those groups. So this is kind of another way to conceptualize where the harms of alcohol are occurring. And what we've done here in this article, we've divided drinkers, lifetime drinkers, into 3 groups: people, former drinkers, those who used to drink but don't use alcohol anymore. And then among people who drink currently, we divided them into those that drink above and below the current Canadian low risk drinking guidelines, because we wanted to see the amount of harm that was experienced by those drinking within the guidelines. Canada's low risk drinking guidelines are currently quite high, quite, you know, liberal from a global perspective. So we were interested in that. So that's another piece that Intermap can help with. It can divide drinkers into drinking groups and estimate the harms experienced within those two groups. So that can be important for policy work, especially around things like low-risk drinking guidelines. So I want to take 5 or 10 minutes and just talk a little bit more about an example of use in 3 different countries, in Canada, Finland, and in New Zealand, just to kind of delve into the type of things that Intermap can help your team with. Some international examples of use. So in Canada, we use it for our national cost of substance use study, which is called the Canadian Substance Use Costs and Harms Project. We do that project here at our institute, CSER, with our colleagues at the Canadian Centre on Substance Use and Addiction. They've been great partners for us throughout that project. And so what we do is, we're actually in this one, we're looking at 8 substance use categories, including alcohol, and that's what Intermap is used for, but we're also looking at tobacco, cannabis, and opioids. And then we're estimating the harms, but also the social cost, the cost borne by society across 3 different main domains of cost: the healthcare cost, cost in terms of the economic loss of production due to substance use, including alcohol use, and criminal justice costs as well. So yeah, I'm talking a little more broadly about our national cost of substance use study, but I just want to be clear that the Intermap model, of which this presentation is largely about, is only focused on alcohol. So although you're hearing those other substances, that's not something that Intermap will help you do. And within those 3, so there are 3 main domains, the 3 on the left, and then there's another catch-all domain, which is called other direct costs on the right-hand side. But so Intermap can help with the first 2 of those. So it can help with helping you calculate the healthcare related cost that's caused by alcohol. And also it can help you calculate the lost productivity costs that come from, that are caused by alcohol as well. So just briefly, some results from that study. It's kind of to show what can be done. Not that Intermap was responsible for all of this, but it did assist the team in working towards these final results. So it's kind of an idea of what Intermap can help your team do. So when we ran through the national cost of substance use study, this is in Canada, we found that most of the costs are from those legal drugs, from alcohol and tobacco. Now cannabis is legal as well in Canada, but that wasn't the case in the study year, which is 2017. So the overall economic cost of substance use in Canada was estimated to be $46 billion. Very large, I mean, this is very important for policymakers when they're thinking about how to basically think about saving money from these very high substance use related costs. And so the last line there, the legally available substances, alcohol and tobacco, contributed almost 2/3 of all the substance use costs in Canada. But, and this has been the case for almost 2 decades now, alcohol is the most, it costs society the most. Alcohol is the most costly substance in Canada. So the leading cause of economic costs associated with substance use in Canada, about 42% of all substance use related healthcare costs are caused by alcohol. So that's, yeah, again, important for policymakers who are thinking across the substance use spectrum, which substances to focus on. It's important for priority setting. And some results from that study, alcohol caused in 2017. This is a different study year than the previous one that I talked about. So That's why the number of deaths is higher. So now we're up to 18,300 deaths caused by alcohol in that year. We were able to use Intermap to estimate that about over 100,000 hospital visits, which are quite costly. Those were caused by alcohol in that year. And also about 20% of violent crimes in Canada are caused by alcohol or alcohol attributable. I'll go through this one a little bit quicker, but this one, so the one in Canada that I just talked about was about estimating alcohol's burden of disease. But this one in Finland, I wanted to show it because what it's going to look at is the impact of policy changes on that burden of disease. So those are kind of like two of the three main functionalities of Intermap, as helping your team estimate alcohol-caused burden of disease. And then secondly, estimating the potential impact of alcohol policies on that burden of disease. So here, so what we did in this study was we wanted to have a study of the policy changes that would occur if Finland's partial retail monopoly was removed. So Finland has a partial alcohol retail monopoly. The government runs stores, alcohol shops that sell about half the alcohol in Finland. So what we wanted to look at was what policies would change if that was removed and alcohol was sold completely privately instead of just about that 50%. So we looked at a policy analysis regarding what that would do from the literature, what that would probably do to alcohol price, what it would do to availability in terms of the physical availability of alcohol, the number of stores and so on. And then we used Finland-specific data like you would if you used Intermap from your country or your region, data on drinking levels, alcohol use per person, patterns of drinking, some binge drinking information, and then that healthcare information, data on hospital admissions and deaths, mortalities. So that was the report that we ended up coming up with. I'll go through a few more slides about this study just to show how Intermap kind of facilitated that project, helped us to do more than we might have otherwise been able to do. So again, this is in Finland. We wanted to estimate the extent of those major alcohol-caused harms in Finland and some of their economic costs. And then, so Intermap helps with aim 1, but then in aim 2, Intermap drives this part. How would the harms and costs change under different policy scenarios? That's where the international model of alcohol harms and policies can really shine, because it's helping us understand what the effect of policies would be, alcohol policies. So we did two scenarios. I won't go into these in very much detail, but so in the first scenario, the alcohol policies were strengthened from a public health standpoint. So they were strengthened to be similar to the neighboring country of Sweden. And in the second scenario, the alcohol retail monopoly, which is called Alko in Finland, was removed. And so alcohol sales were totally privatized. So it's kind of how it is now, and then one where policies were strengthened and one where policies were loosened, from that public health standpoint. And so we looked at the alcohol policies. We identified 5 policies that would be expected to change under either scenario. Things like average and minimum price, opening hours, whether or not stores are open on Sunday. And then we looked at how that would change, how that would impact alcohol use, alcohol consumption, how these would move around. So that That part isn't done by Intermap. It's important to note that any policy analysis, and this will be talked about a bit in the next presentation by Pablo and Bert, because this is what they're working through in Chile. Any policy analysis is done by the team because it's very context specific. It's not automated by Intermap. That's something that needs to be done within your region because it's really quite specialized in that way. But what comes out of that policy analysis is an estimated change in alcohol use. And once we have that estimated change in use from the potential policy that, or the realized policy that may be implemented, Intermap can help automate the impact of that consumption change on harms. So that's the third bucket here, which is about those harms, you know, the alcohol caused harms. How would those change in the different policy scenarios? That's what Intermap is going to help your team do. How would the number of deaths caused by alcohol change? Something that policymakers really key on. If you can save lives, you know, if you can extend the health of the population by preventing death and disability. How would the number of hospitalizations change? Something that's important for healthcare costing. If you can reduce those hospitalizations, it'll save government's money, it'll save society's money. And then in this project, we built costs on top of that. Again, not something that Intermap automates, but we need that costing information on a region-specific basis. So this is to show that the type of things, the type of conclusions that Intermap can help facilitate. So in Finland in 2018, using Intermap, we estimated that alcohol caused about 4,000 deaths, almost 50,000 hospital stays, which is really quite high for the population of Finland. Almost 3,000 cases of long-term disability and many crimes, you know, almost 250,000 crimes. And that cost Finnish society about 1.6 billion euros. Now introducing, strengthening those alcohol policies to make Finland more like a neighbor of Sweden, we found that it would decrease alcohol use by about 16%. And then what Intermap helps do is estimate how that then flows through to the alcohol caused harms. So it would, a decrease in consumption of 16% would reduce alcohol deaths by 21%, hospital admissions by a very large 32%, and costs down by 24%. So again, this can really speak to policymakers as they're looking to kind of save, first of all, save lives and protect health, and then also to save money. And on the other side, where that the alcohol policies were loosened, where alcohol was allowed to be sold privately, would increase consumption by 9%, and deaths would go up, in this case, 14%. And you see those other numbers there. So in this case, you know, the loosening of alcohol policy, we can really hammer home, Intermap can help us hammer home how those policy changes result in, result in less health in the population. You're going to be causing, alcohol is going to be causing more deaths. Society is going to be incurring more costs if those policies are loosened. And that was kind of a general conclusion that we had, that fewer restrictions on the sale of alcohol creates an efficient market for delivering alcohol to the population. Therefore, alcohol use tends to go up, and therefore harms caused by alcohol tend to go up. And lastly, in the international examples of use, this was a neat one. I think we started this about 1.5 years ago. So New Zealand, through their health promotion agency, I was interested in building a national alcohol harms monitoring system that estimated the death and disability caused by alcohol in New Zealand by different health regions, by South and North Island. So when the Health Promotion Agency put out a request for proposal, that it actually requested that whoever won the proposal used Intermap to do the estimation. So that was a good one for our team to see that kind of being adopted around the world. So that's a project that I'm a consultant on. So they put in, of course, data on drinking levels and patterns that are New Zealand specific. And we're just about to the point where that is going to come out, probably in the next 2 or 3 months, that national alcohol harms monitoring system will be in place for New Zealand. And then just about wrapping up here, but I have 3 or 4 more slides. And what I want to do here is just give a bit more of a flavor about the information that you would need to be able to run Intermap. If you're listening to the presentation and thinking, that sounds like something we might want to use, it might help us be more productive and do more work in alcohol epidemiology and policy. What would we really need, kind of the functional nuts and bolts to run Intermap? So what regions need is regional alcohol use information, such as we need things like the prevalence of alcohol use, how many people are drinkers and not, the prevalence of binge drinking, so that binge drinking can be defined differently in different countries, and that's okay, but we need a measure of binge drinking prevalence within your country or region. And then it helps to have the prevalence of former drinkers as well. So people that are currently drinking, former drinkers, and lifetime abstainers, people that have never been an alcohol user. And it's typically needed by some genders or sex and age groups. Many countries have that information, but not all, so it's good to put that out there. Another big component that really drives a lot of the work is we need an estimate of the total alcohol use per capita, either from surveys or from sales or tax receipt information. That's kind of more official sources. What's the total level of alcohol used within your region? That's an important that's an important piece of information that underpins all this work. The alcohol use per capita, say in liters of ethanol per year, is often how it's reflected. And then we also need to have a look at some type of administrative health data, or, well, it doesn't necessarily have to be administrative, but health data such as the number of mortalities, the number of hospital visits or emergency department visits. Those are the harms that we're going to estimate alcohol's contribution to causing them. So we need some information like that, again, typically by gender or sex and age group. And then so a little bit behind the scenes, but I'll go through this fairly quickly. So functionally, what does Intermap do? What it does is it automates the estimation of those alcohol attributable fractions. So if we think of a health condition like, let's take liver cancer. Alcohol causes liver cancer, but even among those that don't drink, they can get liver cancer too. So alcohol basically causes a percentage or a fraction of all the liver cancers in the population. That's what an alcohol attributable fraction is. It's the percentage of each alcohol-caused health condition that is caused by alcohol, or specifically in an epidemiological sense, that would not have occurred in the absence of the exposure to the harmful agent, which is, of course, alcohol. And so Intermap estimates that calculation of alcohol attributable fractions across lots of different health conditions, regions, years, genders, age groups. It does it very quickly. Provides that unique alcohol attributable fraction estimation for all of those different groups. Probably too technical for this presentation, but just very briefly. So yeah, the way that the alcohol attributable fraction is calculated, it's an extension of the classical form of the population attributable fraction made continuous. This is something that Jürgen Riem and others worked on. So there's a continuous distribution of alcohol use, and then there's continuous relative risk functions. I'm just going to kind of move past this. This is from a previous presentation. Yeah, so that's what I wanted to talk about today. I know we'll have these, thanks very much to Pablo and Bert and Tim for doing case studies after this. And of course, I'll be around as well for questions at the end. So thanks very much for coming, and look forward to hearing from you.
Great, thanks, Adam. Pablo, do you want to pick up? And we're doing the Q&A toward the end. So.
Bueno, ¿qué tal? ¿Cómo están?
Good afternoon. For us, it's well into the afternoon in Chile. Cordial greetings to all of you connected here. It's a pleasure to see you all here to share this very important experience. I'm here with me, have here with me Bert Kempfe. We're part of the mental health department of the health ministry in Chile that determines alcohol-related policies. We use Intermap to estimate alcohol use data of use for public health purposes. I'll talk about that. Our experience using Intermap, which we're using to estimate the impacts of alcohol consumption. And Bert will talk about the current status of this methodology. So, alcohol policies and its social and health consequences. In Chile, we have a national alcohol strategy, which is a document published in 2010. And its lines are very user-friendly, are aligned with WHO lines. We are talking about social policies for alcohol consumption, so not restricted to the health area. Availability of alcohol, traffic, etc. All from 2010 to date, we can see some aspects in which we have made strides forward, others not. So we need to do predictions for the next few years. There's an article which I'm showing here on the screen, where you can find a systematic review of policy developments and evaluations in Chile. And it shows under the global alcohol strategy, we can see that we have advanced in health services response and case detection. This had coverage also during the pandemic. And it had links with the administrative issue. We still have these barriers in coverage. We also have an inadequate development because we reduced, there were some laws that increases penalties such as alcohol-caused accidents. And then there are availability of alcohol, pricing policies. At the beginning of last decade, there were some data recovered. And we can also talk about the tax structure. This is the interpreter. The sound is not coming very clear from the speaker. Then we have line area 6, marketing of alcoholic beverages. Last year, a law was approved that regulates alcohol publicity. We didn't have alcohol publicity regulation. Now we do have it. We have regulations of publicity and sports events and similar, and also in highways, with also content publicity. So we have a legal framework, but we are also determining policies. Now, how we translated the national alcohol strategy. We have information about publicity control of alcohol availability, also monitoring. Also, there's retail sale is also regulated. And of course, this seems to be the lookout for the next few years. So these are the areas in which we are applying the national alcohol strategy. We need the consensus of many different actors to properly apply this strategy, and so require not only specific information, but also just information that justified the adoption of decisions. So we want to generate discussions and exchanges of viewpoints. And SAFER is help in this sense. We have challenges in the availability of information. All this goes to say that at some point we are addressing these challenges. We use the SAFER line, and what we have done and the projections indicate the roads to follow. And so at PAHO, the invitation we received by PAHO to talk about Intermap was a great opportunity because it was very germane to the moment in which we are developing our public strategy. Because we need to promote certain changes. We have tax revenues from alcohol, but we still needed year-specific data linked to the development of certain policies. And that's where Intermap came in handy. For example, there's a study that not all countries may have, the impact of prices on alcoholic beverage consumption in Chile. I know that not all countries can have this data, but this data is not there in all countries. We have to wonder whether there's a systematic approach. There are different social and economic differences in the countries of our region. We need to estimate the own and cross price elasticities. Maybe this is not very user-friendly. The upper part is the prices, the elasticities, the price elasticities of beer, wine, and spirits. And here are the crossed elasticities. I apologize for being so technical, but this is a really very specific. It's the price elasticity of certain spirits. And we can estimate what would happen if prices increased 1%, for example. What would happen if prices increased by 5%? And using the elasticity data we have in Chile, we would be able to calculate the impact of the increase in the consumption of beer, wine, and spirits. Change in beer consumption, a reduction of almost 1% in consumption. The total impact also, you can see it in bold, weighted percentage change in sales volume. That in the scenario 1 and also in scenario 2. This is a possible exercise of a study conducted by the health minister in Chile, but I am not a specialist in mathematics. So this is just an initial scenario. If you increase alcohol price by 1%, use would go down by 0.85%. If you increase the price by 1%, in scenario 2, consumption go down by 4.27%. What happened if consumption changed this way? What would be some changes at a social level? And now I give the floor to Bert, who will go into greater details of specific cases. Good afternoon, everybody. Thank you for the invitation. What I'll show now is the process we are developing at the health ministry in Chile to estimate the alcohol use impacts in terms of population health. I always like this cartoon because this reflects what we're doing. My question is, are we making an impact? Are we having an impact? I always like this cartoon. Part of the use of this information facilitated by Intermap makes it possible to consider quality measures as to the impact of consumption on the population, and thereby we can have an impact on public policies in this area. When we started using Intermap, there's a process to use the information. This is what I'll show during this presentation. First of all, as part of the process of we need to identify the sources of information in each country. Then you need to adapt the information to the Intermap format, and then you need to construct input databases that are an input to Intermap, and then you do an analysis in the Intermap page or application. Intermap has an application and also a website format. You can also download the entire app, which is quite flexible. And finally, you use results to inform decisions. This works of a consistent and orderly process as an investigation, as a research and complex two-way process. When you identify the information sources, you identify initial limitations in the available databases. Then there's an identification of possible solutions, and finally, the implementation of possible solutions. The scenario for those who use this tool is varied. You can use population surveys or national statistics adapted to the country. There are also national health surveys, expert estimations, etc. The information we use for the necessary input to Intermap are those shown in green. That's why we started taking the estimation as to the population in Chile, estimation on news based on 3 different surveys, and also a health survey. Conducted every 2 years, and also a national health survey for the national strategy. Then the open database of mortality based on the use of alcohol in the previous year. The information we use, we used our National Health Survey in 2010 and 2017. And then we had more specific information. And finally, to make an estimation in the impact on mortality, we took the database of mortality of the statistic department. Remember, at starting of the pandemic, it was standardized and made available. We started doing this from 2016 to date with social demographic details, age, sex, death, diagnosis, etc.
We evaluated similar results, and that's one of the things that, on the one hand, made it stronger and expanded the study, but it made the analysis much more complex in establishing differences between the different surveys. And we'll show you the next step. We assessed the results of the persons that presented the alcohol problems in the last 30 days, and we showed that there was a problem with the alcohol, and they tried to explain why that methodology was being used with the methodologies of the information that we had available. The challenges of the methodology, we need to detect what's the best available information. So the person handling the analysis must know how to respond. What's the best consumption estimator of grams of alcohol available for each country, and how one can check the population that has never consumed or over age 65. That's the things that we found were a challenge. It reached 64 years of age, and the problem was that if we're talking about mortality, and that was one of the things Adam showed us, the problem was that if we left the people over 65 out of the evaluation, we were going to be losing an important part of the effect of the alcohol on health and mortality. And finally, as I said, to know the information requires adequate handling of the data, and do they make sense internationally speaking. It might take time to become more familiar with the necessary databases. And in preparing the information and the management of the databases requires programming. And we actually developed, based on the available information from Intermap, we went from one software format of open code for the transformation of the available mortality rates, in case the researchers would want to take this information. In other words, having lists or databases of deaths so that one could estimate in numbers of persons dying due to different causes. So we need to use and interpret the population surveys. We need to manage and exploit the databases. You need people who know how to handle the information, who has knowledge regarding the evaluation of alcohol consumption and the prevalence and local policies of alcohol consumption. That was what we learned from this, and what we found was required as part of the development process in the use of this methodology. The current Intermap process, well, this table that I'm showing you now is the input table of corrected information for Intermap. This is the input into Intermap, and it may seem complex, but it's really not. What we see here are the acronyms and the number of, or the rate of persons who've been abstinent, persons who consume binge drinking. That's a current frequent estimate for populations. Then we have the persons who've shown drinking, or former drinkers as he called them, and the other column which shows, oh, I lost it, he says. Oh, the one before, please, the one before. Yes, what it shows here are the correction factors which WHO provides, and consumption of alcohol in the population. And the last is an adjustment factor, which we also had to correct. We realized that the estimates, which belonged to 2010, had biases and was, in our case, affected by very high extremes. So we had to reanalyze and reestimate the data. It is a continuous process, as any research is. When you realize that you solved something, then you realize that you have to solve something else, as any research project or information analysis. This table is the next input into the Intermap. This is just an abstract of Intermap, showing the different diagnostic groups. It's user-friendly. That's why it has these numbers. And in this case, it shows the scope of the data, which goes from 2016, 2018, 2020. And then, to be consistent with the information, we didn't limit it to 1 year. It was also part of the conversation we had with Adam, who quite rightly showed us that having 1 year data, one was able to make use of all the information. In this case, less was more. To make it something simpler, which allowed us to follow the analysis better. And what you're seeing on the screen now is the unprocessed result of Intermap. So, of course, this is the detailed, and you see the different causes, the different analytical groups, and the result of this, the AC value, which shows here on the end column, is the number of cases that could be a fraction attributed to the consumption of alcohol. What you see here in the Q is the baseline. What is the situation currently? But the advantage of Intermap is that it allows you to model different scenarios of changes in the decrease or increase of consumption, which is what you see in the Q column. So you're able to see how many deaths are alcohol related and how much it would reduce if we were to reduce maybe 1% of alcohol consumption. So as Paulo was saying before, this allows us to link the modeling of the current situation and take it to a relevant number for the decision makers, such as how many lives would be saved. That's it. Thank you very much. And we'll be talking to Adam about this a little later, I guess. But we also hope we've shown you that this is a process that's available and could be used, though with some difficulties that we didn't want to hide. But it shows that with some minimum resources and the support, it's possible. Thank you all for the invitation to PAHO.
Good.
Bien.
I apologize, I don't speak Spanish, but thank you for those presentations. We need to move ahead quickly because we're running short on time. And so let me turn it over to Tim Stockwell to talk about the impact of minimum price in Quebec.
Thank you, Tim. I hope everybody can see my slides and hear me. Good afternoon and good morning, wherever you are. I want to start by saying that actually the fact that we're having this session today, this webinar, is the realization of a dream that Adam and I had some years ago, that we could make something that would be accessible to everybody to help anybody who's wanting to do alcohol policy research anywhere on the planet to be able to do it much more easily, because we came from a position of feeling that the science behind some of these estimates of harm and how it would change if policies change has been made more complicated and more mysterious and more expensive by many people doing this work. And we felt that some of the universal principles underpinning the work can be made available more easily for people, so that they, by just tailoring it to their own particular circumstances in different countries, can come up with good estimates. Anyway, so this work has been published. It's an example of applying Intermap to a particular policy context, and this is in Quebec, French-speaking part of Canada, and it was funded by, forgive my French accent, I'm going to try and say the Institut National de Santé Publique de Quebec, or INSPQ, and acknowledging my colleagues. I'm just going to touch on a few issues here because we're short of time. So I'm going to move quickly. The aim was quite simply to estimate the health impacts of implementing a minimum unit price in Quebec. So, we've heard this idea that there's a floor price for a particular amount of alcohol and you can't sell alcohol for less than that price. There was interest in this work, I should say. INSPQ is a government-funded agency, and there was interest from the government in conducting this work and answering the questions. And we were contracted at CISA in the University of Victoria to do this work. That's always a very promising start for doing policy relevant research, that the body that makes the policy is actually interested in asking the questions and seeing the answers. So I'll just show you look, I'm just going to, I suppose the relevant context is, I suppose, a bit like Finland's before, is that there's a partial retail monopoly known as the SAQ in Quebec. So they can and do set minimum prices. Actually, they only set them at the moment on beer. There was no minimum price on wine and spirits, and there still is no minimum price for wine and spirits. I'm going to just go straight through to some results so that we don't, so we have time for discussion. We considered 2 minimum unit price scenarios, one in which it was not possible to sell alcohol for less than $1.50 for a unit of alcohol, a standard drink in Canada. It's quite large. A standard drink in Canada is like a 5% bottle of beer of a size, I think it's 341 milliliters. Just an average bottle of beer with a strength of 5% would be one standard drink. So the 2 scenarios would be $1.50 for that or $1.75. So you couldn't sell that amount of alcohol in wine, beer, spirits, anything for less than those prices. So we looked at, as was discussed for Chile and Finland earlier, New Zealand, how that would impact consumption and alcohol-related harms, hospital stays, and deaths. So Intermap was used. There was some work outside of Intermap. It's our Intermap looking at how the range of prices, we had fantastic price data. We had prices on every individual product sold in Quebec. And from memory, there were about 2,500 of those. And we could see the unit prices for each product and could work, and their sales volumes. And we could work out how the price changes, how much of the products would be affected. So I'm going to give you some examples of the sort of material that we were able to uncover, the information we were able to produce for the policymaking process. So we've got the major categories of beer on the left: beers, ciders, coolers, grouped together, wine, spirits, fortified wine or liqueurs. And we looked at what percentage of the products would be affected by the policy change and what percentage of all the alcohol consumed would be, and it varied slightly, would be affected by the $1.50 or $1.75. So clearly the $1.75, the higher price, affected more products, affected more alcohol sales. And you can see on the bottom, 2.5% of products are affected by the $1.50, 5.4% for $1.75. The $1.75 one actually impacts on over 56% of all alcohol sold versus 24% for the $1.50 example. And this slide just shows the average price change in the affected products. So not all products are affected, only the cheap ones, and the price of those products goes up, about 13% in the first scenario, 25% in the second scenario. So how does that impact? The next step we had to do was to estimate what those changes would mean for consumption. And we applied another Canadian estimates of price elasticity. So we used British Columbia, a more conservative estimate, a lower price elasticity for the effective price on total consumption of alcohol. And essentially this very simple step, we just went from, here are the price changes, we applied 0.34% is going to be the impact on consumption overall. And then we use various well-established assumptions about the universal impact of total consumption, how that's distributed in the population, and it feeds into Intermap to come up with estimates of harm. And so similarly, you've just seen for some examples from Chile. Here's some examples of the estimates of the impacts on mortality in different categories. So for Quebec, I think the reference year was, I forget, I think it was 2016. It could have been 2018, but whichever year it was, the estimated total deaths caused by alcohol was nearly 3,000. And we're able to estimate using Intermap the extent to which those would change, there'd be 169 or 6% fewer deaths with a minimum price of $1.50 and about twice that for a minimum price. There's a mistake in my slide. That should be $1.75 there. I do apologize. Moving on quickly. And that mistake is also, the right-hand columns should be $1.50 and the next one's $1.75. But basically the same thing for hospital admissions. The grand estimate for the year in question was nearly 25,000. And the $1.50 scenario for minimum price reduced that by over 2,000 hospitalizations and more than 4,000 for $1.75. So we recommended in the reports that there would be major public health benefits from introducing a variation of this policy. And this was provided to the policymakers in Quebec. I believe they have considered it seriously and it may come to pass at some point in the future, who knows? But we can't guarantee results. We can only, open windows and say, well, if you take this course of action, this could happen. And so I think I'll leave it there and I hope that gives you an illustration of the power of Intermap for informing policy. Thank you.
Excellent. Thank you very much, Tim. We have time for a few questions, I think. So I'm going to go ahead and read them, and Maristella will chime in if because some of them are coming in Spanish, so I need help. But we have a question to lead off. I think this would be most for Adam, somebody who works with fetal alcohol spectrum disorder, who was interested in modeling the economic impact of that. So the question is regarding the methodology to be used in terms of how alcohol consumption affects pregnant women. I'm interested in being able to estimate the economic impact of consumption in this case, if this is possible. My problem lies in obtaining the data since it's a disease considered rare with a prevalence of less than 2%. So if the diagnosis is not given in hospitals, then there'll be a problem. Adam, any thoughts on pregnant women or looking at FASD, fetal alcohol spectrum disorder?
Yes, first, let me say thank you so much to Bert and Pablo and Tim. I really appreciate hearing those different perspectives. So interesting and if I could say like rewarding, for our team to see that Intermap is in use in Chile. Thanks so much for working through that. I really appreciate it. To the fetal alcohol spectrum disorder question, this is a very challenging issue, certainly for society, but also analytically. FASD is not included in Intermap. So in terms of this presentation, it's not one of the health conditions that would be looked at. It's very challenging. I know there's work being done on FASD in Canada's Center CAMH, the Center for Addiction and Mental Health, also another WHO collaborating center. But in terms of the Intermap component of FASD, it's not included. So I won't speak to that anymore. Sorry to not be able to help further.
Thanks, Adam. Then we have another question about the differences in Intermap and the GB compare tool that's available online, and also with the comparison of Intermap with the Sheffield alcohol policy model, which has been used for minimum pricing assessments in Scotland. Can you kind of summarize briefly some of the similarities and differences?
Sure, yeah. Those are great questions. Thank you for asking them. I'll start with the Sheffield alcohol policy model. The Sheffield alcohol policy model is an excellent model. We know we've worked with the folks at Sheffield quite a lot. The Sheffield alcohol policy model is proprietary. So it costs, as far as I know, it's significant outlay to run that model. It's far more complex than Intermap because you need many, many data inputs. You also need the Sheffield team to work with you, and that, you have to pay for it. So Intermap is simpler because it is available for everyone. So the research teams need to be able to come up with their own information. put that into the application. SAPM, the Sheffield model, needs a much deeper level of data. It's a larger undertaking to run SAPM, and it costs significant dollars. In terms of global systems, so you mentioned the global burden of disease, which is done by the Institute for Health Metrics and Evaluation. The other global system is WHO's, the Global Status Report on Alcohol and Health. Both of those systems are good systems, they're excellent systems. What they can't do in both cases is the policy modeling component. So that's something that's unique in terms of available tools, freely available tools, unique to Intermap. Sheffield Alcohol Policy Model also does, it's called a policy model. So they also do policy modeling, but it's not freely available. So those kind of add additional functionalities are unique to Intermap compared to the other two global tools. What I want to do is very quickly show my other screen. Right, I saw that question in the chat. So Tim, Naomi, can you see this where it says Intermap?
Yeah.
Okay, so this is the landing page for Intermap. And so we're gonna, and there's information there, a lot more if you want to go to that website, but I'm just going to launch it and I want to show you what can be done. So the biggest difference between those two global tools, the Global Burden of Disease and the Global Status Report on Alcohol and Health, is their relative risk functions. So they're done differently. They basically build a library of relative risks, and the relative risks are the risk of alcohol use for all of those health conditions. There's about 25. So those libraries are quite different for the Global Burden of Disease and the Global Status Report. In Intermap, we have them both loaded here where if you can see my cursor under relative risk source, these are the libraries of relative risks, and each team can choose which they please. Right, so there's the Global Burden of Disease, there's WHO's library. We have both of those custom loaded. It's automated in Intermap. And then we have a third one, which is specific to our national cost study. So that Intermap is more flexible. Those global systems are both good. I don't want to talk poorly about them, but Intermap allows greater customization, and it further allows policy analysis.
Great, thank you. Maristella, we have 5 minutes left. I can give one more question, or do you need to jump in?
I think I need to jump in, okay. Because I have another call at 2:30. So I want to close this obviously thanking all of you and the interpreters and Ilana, Daniela, who helped organize this. And this webinar comes in a very timely manner because we just got the Global Alcohol Action Plan approved, and member states now need to be collecting their information, data, and using it for policy analysis and development. So I think the interest we got today is a reflection of that. And I hope countries will reach out, ministries of health, and will be happy to collaborate along with CSUR on using the tool. And why it is beyond the tool, it is so important to have standardized data, standardization of the way indicators, variables are collected, so we can compare and better understand where each country is in terms of not only the harms, but what are the options that they can consider for policies. And so the examples, and that's why I'm so thankful for what Chile presented today. The more countries that follow this example, the better we all are going to be in the region, and hopefully globally. And this can steer collaborations and data analysis beyond just a country level, but comparing several countries. And also because the model policies, and this is what everyone is searching for. What can I do? What if I do that? What benefit we will get? And now we have a roadmap from WHO, and each country can use, adapt, and be better guided to what needs to be done. The other advantage of the tool is open access, and it's freely available. That's fantastic, and that's what PAHO wants to do with the tools. We develop courses and opportunities like that. We're going to have technical support from a high praise and center, and that is because it is also a PAHO WHO collaborating center. It gives the standards that countries need and look for, instead of just picking and choose a research institution. They may be as good as, but there are certain standards that comes along with working with PAHO and WHO. And is also interesting that we had participation from some members of the alcohol industry in this webinar. So they want to know what countries are doing, what they're planning, and probably to counteract the findings. And we know already of initiatives in certain countries to go against alcohol taxes, to help anyone in a country to talk to legislators, to go against proposals to increase taxes. So it's important to know that we are on a balance, that we have two sides of the coin, and it's not because a plan was approved that is going to be implemented as is, and it's a competition. We have public health on one side, and we have commercial interest on the other. So it's a conflict of interest that will remain forever, and we in all countries and all advocates need to be aware and use the best information they have to convince policymakers on the way to go forward. So I'm going to end. Really thank you guys. Thank CISUR. The development of the tool is really a public good, and that's the business of PAHO. So thank you very much for everyone who participated. We're gonna send the recordings, and I hope to see countries contacting us to receive more training in the use of the tool. Have a great day.